As a nephrologist, I was involved in the EMPA-REG outcome study, which was a cardiovascular outcome study published in 2015. And as a surprise to everybody, to investigators, to scientists, to the world, this study opened up a huge field where many SGLT2 inhibitors now entering and do outcome trials. And I'm now looking, when I wrote my article in Diabetologia, I was asked to look into the future. Into the future because as a nephrologist, I was overlooking the kidney outcomes, and kidney outcomes were a secondary endpoint in the EMPA-REG outcome study. And the result was so beautiful. The kidney endpoint, which was called worsening of nephropathy, was reduced by 39%, which is tremendously high in his risk reduction, more than all other trials currently available are showing. However, you must see that the endpoint, the kidney endpoint, was driven by macroalbuminuria, which is not accepted by regulatory agencies. And since it was a cardiovascular outcome study, not prepared for studying doubling of serum creatinine or dialysis, there were not so many endpoints. And the kidney in the secondary endpoint, not being statistically alpha controlled, not all parameters sustained, means that we require new studies where the kidney is in the primary endpoint to be really sure that we are close to the truth. So far, with the surprising result in EMPA-REG outcome, with the retarding the progression of kidney disease, it's nice to have the result. It was confirmed by the CANVAS program study. So we have two outcome studies, cardiovascular with the kidney in the secondary endpoint. One study is confirming the other. We are coming closer to the truth. But to be sure, we need for an appropriate label and for the regulatory agencies, we need outcome studies where the kidney is in the primary endpoint. And these studies are ongoing. They started a study with dapagliflozin, DAPA-CKD, chronic kidney disease, and EMPA-Kidney, an outcome study with empagliflozin in as the intervention. And I think we will see in a couple of years, 3 years, the result, and we can be sure that we can avoid dialysis in many patients. That's the question. Avoiding progression of kidney disease, avoiding dialysis. And this would be tremendous, a tremendous advantage for our patients, since we did not have trials for the past 15 years, which gave us the opportunity to go in this direction. We are understanding the mechanism of the intervention, and the mechanism tells us that with an anti-diabetic, we may have the chance to retard progression of kidney disease in non-diabetic patients. And this is something very exciting, because we can lower the pressure in the glomerulus, we can reduce the hyperfiltration, single nephron hyperfiltration, that's the hypothesis. And this means we retard the progression of every other kidney disease which goes along with hyperfiltration and high intraglomerular pressure. All other kidney diseases, such as glomerulonephritis, for example. And these patients will be included in the outcome trials which have started to recruit patients worldwide. That's what is exciting for a nephrologist. Second, for the future, cardiologists or heart failure cardiologists were so excited because with the osmotic diuresis, you get, let's say, this single hypothesis. There are more mechanistic ideas behind. With the osmotic diuresis, you get a reduction in hospitalization for heart failure. And this endpoint is reduced nearly the next day when you give the medication. It comes very rapid, and it provides also a huge opportunity to treat special forms of heart failure, for example, diastolic heart failure, where we do not have powerful treatment so far. And if you now go into the mechanistic details, similar to the kidney, we think that by using osmotic diuresis, we can also treat heart failure in non-diabetic patients. So this is the next series of kidney with EMPA preserved and EMPA reduced, the name of the trial, and the heart failure, DAPA heart failure. And now other companies are coming with other SGLT2 inhibitors and SGLT1-2 inhibitors combined entering in this field. In Japan, we have 7 SGLT2 inhibitors already on the market, approved. So we will see a variety and beautiful data in the future in high risk and lower risk patients. And this is very exciting.